All right. Well, welcome everyone to the World Health Network Twitter Spaces. We are really excited today to talk about long COVID. We have a very important discussion ahead. We're going to be chatting with our two doctors, and then we're going to move on later in the chat to take questions from the audience, and I will let everyone know when it's time to ask questions. But before we get started, let me invite you to visit our website, worldhealthnetwork.global, and be sure to be following us on Twitter and Instagram. We also have a great newsletter, so I invite you to subscribe to our email list so you don't miss out on important updates, news, and exciting upcoming events. So also today, we're going to be making a special announcement relating to our long COVID work, and I can't wait to tell you about it. If you're new to the WHN, we welcome you to join and become a World Health Network member. We have a great supportive community, and I would love for you to join. So now let's introduce our speakers. We are so excited today to have Dr. Claire Taylor, a family medicine doctor from Scotland, who in fact runs a long COVID clinic, and also Dr. Ray Duncan, a cardiologist specializing in long COVID. So let's get started to hear a little bit about the backgrounds first and how folks got involved in the long COVID fight. So we'll start with you, Claire. I'd love for you to share with us about your background as a general practitioner, your volunteer charity work, and how you came to open a long COVID clinic.
Hi, nice to meet everybody. So I was interested before the pandemic in things like POTS and done lots of other jobs before general practice, including supervising tilt tests and seeing patients with POTS, and then doing some rheumatology jobs and seeing patients with lots of multiple symptoms but nothing in their bloods and no diagnosis. And then when I went into general practice, tended to take on those sorts of patients to try and work out what was wrong with them. And in early 2020, when we heard about COVID, thought, oh gosh, we're going to have a lot of post-viral patients here. And got myself involved, first of all, through the charity, doing virtual consultations because everything was shut down. And then when that stopped at the start of the year, thought, how can I continue to do this? And unfortunately in Scotland, there wasn't any way in the NHS of running a clinic. So I have, through necessity of patients not really having anywhere else to turn, have set my own one up. So that's just how I am here. But also very interested in all the research and very involved with all of the people that are doing the research, and hoping to do some research myself as well.
Great. Thanks so much. We're so glad to have you here, Claire. Thank you so much for your time.
Great to be here.
Thank you. All right, Ray, could you tell us about your background as a cardiologist and how you became inspired to focus your work on the effects of long COVID? Hi, Ray. Are you able to unmute?
Oh, can you hear me now?
Oh, yeah, we can hear you just fine. Great. Yeah, so could you tell us a little bit about your background?
Sure. Hello, everyone. So my name's Ray, and as Katie said, I'm a cardiology consultant. I'm based at the Newcastle Hospitals NHS Foundation Trust in the United Kingdom. I'm also Scottish. So I already had an interest in infectious diseases, and actually my first university degree was actually in medical microbiology, so virology, bacteriology, and immune response. And for a little while, I thought I wanted to be an ID specialist and work for the World Health Organization, but that was before I got bitten by the cardiology bug and decided to train as a cardiologist. I too also have an interest in research, and I have a couple of postgraduate degrees in cardiovascular research as well as my cardiac qualifications. So I first really got involved in COVID work right at the beginning of the pandemic, when I was rotated out of cardiology and I was re-rolled to go and help run an acute COVID ward at the Royal Victorian, which is one of the principal two HSID specialist infectious disease hospitals in the United Kingdom. And what we noticed in Newcastle fairly early on was that patients, after being discharged, just weren't really recovering the way that we expected. And when my colleagues in the Departments of Infectious Diseases and Respiratory Medicine set up the first long COVID clinic in the United Kingdom in Newcastle, I set up alongside them what I believe was the first post-COVID long COVID cardiovascular complications clinic, which I then ran for around a year. And that had quite a profound effect on me, actually. Some of the patients I was seeing were incredibly sick. Some of them had complications, cardiovascular complications that were recognisable and treatable, like myocarditis and POTS, postural orthostatic tachycardia syndrome, which Claire's going to talk to you about in a lot more detail later. But there were others that were incredibly sick, and I didn't know really at that stage what was wrong with them. I knew they were sick because they were telling me they were sick, and I could see they were sick, but all their standard blood tests and imaging tests were coming back normal. And I knew that we were missing something potentially huge. My patients were telling me, the ME/CSF community were kind of shouting it from the rafters, but we didn't actually know what the underlying disease process was, the pathophysiology, and without understanding what this virus was doing to the body, I didn't know how to treat it in some of these patients. So the upshot was I didn't know enough, and that's quite an uncomfortable position for a physician to be in. But to just admit when you don't know enough and go away and learn about it. So now, by the time the patients in my clinic had come to see me, often they'd already seen 2 or 3 different doctors. Many, like me, knew there was something very wrong, but they just didn't know what it was. But there were others, unfortunately, who just simply didn't believe that long COVID existed. And by the time the patients had made it to my clinic, some of them had been told there was nothing wrong with them. It was all in their heads. They were just anxious. They were just depressed. They were just unfit, etc., etc. And when you finally sat them down and said, "I believe you," they cried, and it was horrific. And it was heartbreaking. And so really, one of the things I wanted to say that as doctors and clinicians, we have a duty of care towards our patients. And if we don't understand our patient's illness, we have a duty of care to go away and learn it and to understand it, and we can help them. And if we can't do that, we do have a duty of candor to tell our patients we can't do that and to refer them to somebody who does. What we mustn't do when we don't understand our patient's disease is assume that the illness doesn't exist. So in amongst all of this, while I was running this clinic and I was learning as I was going, I was still working on the front line. And like many healthcare workers, especially in the UK, when our government and our public health department decided to downgrade our PPE against WHO guidance, a lot of us got infected and a lot of us got sick ourselves. And myself and many of my colleagues have actually been infected with COVID ourselves several times. And at one point I was quite ill myself. And although I'm much better now, I can still remember what that felt like. And so I can only imagine that the only thing worse than, I know many in the audience will be living with long COVID that are listening to this, I can only imagine that one of the things worse than living with a severely debilitating chronic invisible illness with no recognised treatment is living with severely debilitating chronic invisible illness and not being believed. So
Absolutely. So here we are now, Ray, 2 years into the COVID pandemic. So how big is this problem? I mean, how big of a deal is long COVID and the post-sequelae for long COVID?
So really, it's a huge deal. The pandemic is far from over, no matter what we're being told. If we look back in March in the UK, at the peak of Omicron, there were 350,000 new infections per day, and that was in the people who were actually testing. We're 2.5 years into the coronavirus pandemic now, and over 6.4 million people have died, and 100 million have been left disabled by long COVID. The World Economic Health Forum estimates that COVID has already cost the global economy $11 trillion and is predicted to cost another 10 trillion in workplace absence going forward. So unfortunately, some of you may be aware that a recent Nature preprint paper has also demonstrated that the current reinfection with SARS-CoV-2 also increases your risk of developing long COVID. If we look at the Office, just very briefly, the Office of National Statistics, the prevalence of long COVID in the United Kingdom was 1.1 million in April 2021. It was 1.3 million by January 2022. The government ended all legal COVID restrictions in February 2022, and by May 2022, the ONS reported 2 million individuals living with long COVID. So the post-acute sequelae of COVID-19, in my opinion, is the biggest public health crisis of this millennium, and it will be felt for decades to come. And I believe there are 2 urgent needs for those living with long COVID. The first is to find a biomarker that has both diagnostic and prognostic value. And the second is to find safe and effective treatments that can help improve symptoms and level of disability. And this is part of the reason that I actually changed my entire job plan. I went and I joined the team Clots. I got involved in an international research collaboration. I joined the WHN. I became a long COVID kids medical advocate. Because we need to learn more about this, we need to research more about this virus so we can treat our patients better.
Thank you so much. Yes. So we're just being bombarded all the time with things like the pandemic is over, you just need to move on and live with it, get on with your lives. So can you tell us what long COVID is exactly?
Sure. So that, I mean, it sounds like a simple question, but it's a really, really good question. So the definition of long COVID or post-acute sequelae of SARS-CoV-2 or post-COVID syndrome or post-COVID condition, all of the same names, different names for the same thing, depends actually on what country you're in. In the United Kingdom, long COVID or post-COVID syndrome is defined by the National Institute of Clinical Excellence as signs and symptoms that develop during or following an infection consistent with COVID-19, which lasts for more than 12 weeks and not explained by an alternative cause. WHO case definition is that post-COVID-19 condition occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually within 3 months of the onset of the acute infection, and it lasts for at least 2 months and cannot be explained by another cause. Long COVID is a heterogeneous condition with around 200 reported symptoms involving multiple organ systems. The most common symptoms: fatigue in 87%, brain fog in 78%, post-exertional symptom exacerbation 86%, and dysautonomia in 38%. So this then begs the question, this is what I really want to talk about just for the next few minutes. This really begs the question is, how can long COVID possibly be one disease when there are 200 different symptoms, different people are affected differently, and multiple organs are involved? Well, the key to understanding what long COVID is to understanding what the underlying pathophysiology of the disease process is. Pathophysiology is the medical term that means the underlying disease process that is going on inside our bodies that are resulting in the symptoms of long COVID. This was the huge piece of the jigsaw puzzle that I was missing when I set up my long COVID cardiac clinic. And this is what I went off to try and learn and find out. And thanks to the amazing pioneering work of long COVID researchers such as Razia Pretorius, Douglas Kell, Jacob Lauster, Akiko Iwasaki, Dave Petrino, Amy Pro, and many others, we're finally fitting together all the pieces of jigsaw. So long COVID is not a respiratory disease. Long COVID is a disease of the blood and the blood vessels. When we think of our bodily organs, we think of the heart, the brain, the lung, the liver, the kidneys, the nerves, etc. But often we forget that our blood and our blood vessels are also bodily organs and fairly vital ones. So our blood contains the cells that carry the oxygen and nutrients supplied to the organs all around our body. Our blood contains the immune cells that fight our infection and the platelets and the other molecules that allow our blood to clot so we don't bleed to death when we cut ourselves. Our blood vessels are also living, breathing organs that produce molecules to help regulate the control of the blood flow, the size of the blood vessels in response to changes in the environment. Our blood vessels, simply put, are everywhere in our body. From the larger blood vessels carrying the oxygen to the organs to the millions of tiny little blood vessels called the capillary vascular beds that allow the blood supply, the oxygen, the nutrients, the clotting factors into the actual organs themselves. So blood vessels themselves, especially the capillary vascular beds, become inflamed and diseased. This would have a knock-on effect on every other bodily system. And this would explain almost all of the symptoms of long COVID. So I want to explain to you now what we believe is happening with long COVID. And none of what I'm about to tell is my opinion. It is simply a condensed summary of current already scientifically proven, peer-reviewed and published literature. So the symptoms of long COVID is not necessarily as a direct result of the virus itself, but of the host response to the virus. So what we're seeing in long COVID is a maladaptive immune response to SARS-CoV-2 infection. And this includes aberrant innate immune responses, cells called non-classical lymphocytes, chronically stimulated immune cells called T cells that become exhausted. These immune cells release these pro-inflammatory molecules called cytokines, in particular cytokines called interleukin 4, 6, 8, and TNF-alpha. The immune system becomes chronically stimulated, and this results in a state of chronic inflammation in the blood and the bloodstream alongside T cell exhaustion. And the presence of these elevated pro-inflammatory cytokines in the blood actually damages the protective lining layer of the blood vessel. This protective lining inner layer of the blood vessel is endothelium. So the endothelium becomes inflamed, and this is called endothelitis. Endothelial damage then stimulates the activation of platelets, which are molecules that are involved in the clotting process. The platelets then stimulate the coagulation or the clotting cascade, a process that's kind of complex I'm not going to go into, but I can post some nice slides of it on my Twitter feed if people are interested later. This causes a hypercoagulable state, which means that blood becomes more sticky and more prone to clotting. So in acute COVID, we can see this, and people develop large clots, and we've seen this already. Clots to the lungs are called pulmonary emboli, cause pulmonary infarction. Blood clots to the brain cause strokes. Blood clots to the arteries cause heart attacks. In long COVID, however, the clots are a bit different. They are much smaller. They can't be seen by standard tests, and you need advanced techniques such as immunofluorescent microscopy to view them. They're also not normal clots. In the presence of viral spike protein, the fibrin molecules, which are the things that are involved in the clotting process, become misfolded into an abnormal protein formation, an amyloid formation, which then makes these particular clots resistant to fibrinolysis. And what that means is it means the clots are more difficult for the body to break down themselves. So the clots don't dissolve in the way they should. And these are the clots that were discovered by Rhizia Pretorius and Doug Kell, and these are known as fibrin amyloid microclots. So these microclots also have molecules trapped inside them, including molecules called von Willebrand factor, which leaches out from the damaged endothelial cells in the blood vessel and the platelets. That then cross-links with the fibrin and makes the clots more dense, again making them harder to break down. And there's also trapped antiplasmin, a molecule that's involved in converting another molecule, I don't go into too much detail, but plasminogen to plasmin that also helps stop breaking the clot breakdown. So what we are seeing, and what we're seeing in our ongoing UK microclot study, which I have permission to share the very basics of, is that actually, for people looked at so far, it's not just people with long COVID that have microclots. Even people who've had COVID infection and recovered without ongoing symptoms have microclots, but just not as many. And so we're wondering, does the microclot burden, is that causing a significant in the development of symptoms? The trial's still ongoing. It's too early to draw too many conclusions yet, but we are studying this further. And that's being run by my colleague, Caroline Dalton, who's heading that up.
Ray, thank you. Can you summarize that in a quick sentence in regards to the immune and vascular systems damage?
Sure, absolutely. So I'm going to tell you the medical term, and then I'm going to just say the layman's term. So in medical terms, long COVID is basically being caused by immune-mediated inflammation causing a systemic thrombotic vasculitis. And what that means is the immune system is having an abnormal response. It's causing chronic inflammation. It's inflaming the blood vessels. It's triggering the platelets in the clotting system. We're getting microclots. They themselves may be immunogenic. They're getting stuck, we think, in the capillary vascular beds, setting up a further inflammatory reaction in those capillary vascular beds, which is causing more immunes to leak out into the other organs and causing inflammation in the other organs. In addition to that, the clots themselves, as they're clogging up or sludging up these capillary vascular beds, are reducing oxygen flow to the other organs, such as the brain, and therefore you get brain fog, so the heart, and therefore you may get microvascular angina, such as the muscles, and therefore you get muscular fatigue when you try and do anything. And that's what we think is happening. And there's lots of now published evidence in the literature to support all of the things that I have just said.
Great. Thank you so much. That was a very detailed explanation, and it's so important that we understand what is going on. So we're going to switch to talking about diagnosis and challenges. So I'm hearing people are just having such a hard time getting diagnosed. People may not even realize they're having long COVID. They're having new symptoms. They're not sure what's going on. It's missed so often and hard to diagnose. Can you talk about this predicament that the medical community and folks are dealing with?
Yes, absolutely. So in general, one of the issues with long COVID is if you don't understand the pathophysiology of the disease, you won't understand the tests you need to do to detect the disease, and you won't understand the treatment options available until you understand the underlying process. And that's why it's so important that everybody understands what's going on. So in general, one of the problems, certainly at the beginning and still ongoing, is that doctors have a list of standardized sets of screening tests that they use in patients complaining of certain constellation of symptoms. And they use these tests, they're usually blood tests and imaging tests, to exclude specific underlying disease processes in their patients. The problem with long COVID is that a lot of these standard tests that we use routinely in medicine are not sensitive enough to detect the abnormalities that are present in long COVID patients. And the reason for that is because long COVID is predominantly a disease of the microvasculature. So often the tests in long COVID come back as normal. Now, just because you have a normal test does not mean your patient is okay. What it does mean is that we're doing the wrong tests. And if you don't do the right tests, you won't get the right answers. And if you don't get the right answers, you won't get the right diagnosis. And if you don't get the right diagnosis, the patients won't get the right treatment. So the best way of understanding what tests are potentially helpful is to understand the underlying disease process. And so as clinicians trying to get involved in long COVID, we really need to be thinking outside of the box and work from first principles so we can work out what tests are actually helpful. So what I'd like to just spend the next couple of minutes doing today is I'd just like to share with you a list of the tests that I have found from my own research, from my own clinical experience, from the clinical experience of my colleagues, and clinical experiences of other long COVID physicians and researchers that I think are helpful in improving the diagnostic yield of long COVID. And so that if everybody started using some of these tests, I think we would have a much higher pickup rate and patients would get better treatment. So one of the things I want to point out, for example, in somebody that's very short of breath, if you're short of breath after COVID, it's not going to wait. We know that COVID can cause blood clots, for example. Now, the standard test we use for diagnosing blood clots is a blood test called a D-dimer, but you have to understand the pathophysiology. A D-dimer is elevated in most people with standard blood clots. A D-dimer is a fibrin degradation product, which basically means as the blood clot starts to break down, this is one of the broken up bits of clot and we can pick it up in a test. However, if you have patients with long COVID who cannot break down their clots, then your D-dimers may not be elevated. So it doesn't necessarily mean that you don't have clots. It means that you just don't have a test that can detect them. Other things that we look at, for example, if I had a patient who had a negative D-dimer but a very good clinical history suggestive of a blood clot in the lung, I personally would still investigate them. A chest X-ray is not sensitive enough to exclude blood clots in the lungs. The next problem is the standard imaging test that we use to exclude a blood clot in the lung is called a CT pulmonary angiogram. Now, I've been reliably informed by my consultant radiology colleague, Dr. Graham Lloyd-Jones, that in patients with ongoing symptoms 3 months post-COVID infection, 8% may have a positive CT pulmonary angiogram, but 58% will have a positive dual energy CT that's positive for perfusion defects. And we think perhaps one of the problems with this is that the CT pulmonary angiogram is very good at picking big clots in the bigger arteries, but because in long COVID there's microclotting, it's not as good at picking up the smaller perfusion defects, the tiny little multiple perfusion defects and things in the peripheries. Personally, I've also found a ventilation perfusion scan quite helpful in helping to diagnose multiple small clots that may have been missed. So I think those are tests that may be potentially helpful in long COVID. The next one is we talk about oxygen levels. So patients with long COVID often feel like they're not getting enough oxygen, but you sit them down and you put on an oxygen saturation monitor and their arterial oxygen saturations may look normal at rest. I would always get people to walk with an oxygen saturation monitor on to see whether they desaturate when they exert themselves, because that isn't normal. Many patients have normal arterial oxygen saturations, but a test that I think is potentially useful is not looking at the arterial oxygen saturation, but looking at the mixed venous oxygen saturation. And this is a simple blood test. It's a venous blood test. We don't routinely test for, but we can. Normal venous blood gas tests are in the region of 60 to 80%. That's a normal result. In patients with long COVID that I have seen, we can see some patients with long COVID having mixed venous oxygen levels of 30% or 40%, sometimes even in the high 20s. And this is clearly not normal, and it is suggestive of a lack of oxygen to the organs called tissue hypoxia. Other things that can be missed in long COVID, Dysautonomia. Claire's going to talk about this more, so I'm not going to go into too much detail other than to say that the autonomic nervous system are the nerves that control our bodily functions, and that's functions such as your heart rate, your blood pressure, your temperature regulation, your bowel and your bladder function. Dysautonomia post-COVID means that COVID is causing the autonomic nerve fibers to misfire and not to work in a certain way and to be out of whack. And the most common symptoms are related to the nerve control to the heart and the blood pressure. So about 38% of patients with long COVID criteria for POTS, which is postural orthostatic tachycardia syndrome. So it means that when they stand up, their heart rate shoots up. Or another one, not necessarily POTS, but a similar related condition is called IST, inappropriate sinus tachycardia, where their heart rate is much higher than it should be, and it shoots up more than it should be when they start to walk or try to do anything. Now, if you just do a simple 12-lead ECG, which is the standard test for looking at the heart rhythm, at rest, that is probably going to be normal. So what you need to do is a Nasoline test where you stand the patients up for 10 minutes. You take their heart rate and their blood pressure lying down after a period of rest, and then you stand them up and you repeat their heart rate and blood pressure every minute for a minute, and you're looking for a sustained rise in the pulse rate to allow you to diagnose the condition. Claire's going to talk about that more later, so I'm not going to say any more on it.
Could we just have you summarize, Ray, the most important standard tests for folks that think they might be experiencing some of these suspicious new symptoms?
Okay, so in summary, the tests that I think that we have available to us and that are helpful for now in certain individuals, not in everybody, just in certain individuals, are exertional oxygen saturations on walking, mixed venous oxygen saturations on a venous blood gas, cortisol levels, possibly dual source CT or a VQ scan in some patients if there's a high clinical suspicion of a pulmonary embolus, but the original tests are negative. Not just an ECG for exertional palpitations, but a Nasoline test. Other things, myocarditis, for example, a normal echo can pick up an echo can pick up myocarditis, but a normal echo doesn't rule it out. And therefore, you have the ability to do additional testing called strain echo imaging, which I've just helped co-publish a paper on, that can pick up these changes in myocarditis post-COVID, or cardiac MRI. But there are other tests that we need to think about developing for the future that are not yet available clinically, but they are available in research, and we are using them within our research group in the studies that we're trying to do. One is cytokines, pro-inflammatory cytokines, predominantly IL-8. Other is microclot testing. Another is testing for endothelial function. Another is platelet activation, and another is looking for autoantibodies.
Okay, thank you. And if you just joined us, we're here talking with Doctors Claire Taylor and Ray Duncan about long COVID. We've covered already in detail what is long COVID, and we're talking about diagnosis and some suggested tests for these symptoms that we may be experiencing. So now, Ray, let's talk about your specialty, cardiology. What are you seeing as far as the major cardiovascular effects after COVID-19 infection?
Well, there's a few things that we're seeing. I mean, certainly, if I'll talk just for a minute about some of the things that I've seen in my own clinic, but then I actually just want to touch on a very important paper that was published in Nature, because I think this is really, really relevant. So some of the things that we see post-COVID, dysautonomia is a big one. So technically, it's not a problem with your heart per se, it's a problem with the nerve supply to your heart. And that's conditions like postural orthostatic tachycardia syndrome and inappropriate sinus tachycardia. Other things that we're seeing is myocarditis, pericarditis, heart attacks. There's a microvascular angina. But if I can just come on to this is a really important point, because for me, one of the things that I have concerns as a physician who is a cardiovascular specialist, but also interested in long COVID, is it's not so much although the acute illness can be very severe in some people, it's not so much the acute illness that concerns me. It's the fact I think that we as a global community have dropped the ball on long COVID and on the cardiovascular complications of COVID. I think they're the two enormous elephants in the room that are not being talked about enough when we're talking about the best way to learn to live with COVID. And so in addition to long COVID being a complication, many of you in the audience will be fully aware that there was a fairly large Nature paper published back in March of this year from the United States looking at about 12 million people and greater than 153,000 of those who'd had COVID, and they followed them up for a year after COVID, and they demonstrate on follow-up over a 12-month period a significant increased risk of cardiovascular and thrombotic events, and those included but were not limited to acute coronary syndrome, myocardial infarction, which is the medical heart attack, cardiomyopathy, angina, heart failure, arrest, atrial flutter, atrial fibrillation, ventricular arrhythmias, myocarditis, pericarditis, pulmonary embolus, deep venous thrombosis, stroke, and TIA. So that kind of blew my mind, really. We knew we were seeing stuff. I don't think we quite realised how bad it might be. Now, one of the things I would say, there may be some compounding factors in this study. This was published in March, and it was after a 12-month follow-up, so it's predominantly relating to patients that probably had either alpha or delta COVID infection. We don't know if it's severe with Omicron. We just don't know that yet, but we certainly need to look at that, and we need to find out. The study was done in a VA cohort, so there were veterans, and I know that there was a little bit of criticism in some quarters about this, with some of them being older, but they did do a subgroup analysis, and they showed that even in young people, even without any cardiovascular risk factors, they were still seeing these increases, and that also concerned me. The other thing that I found really concerning was, some of you may be aware of the Knack Registry data that was presented in May this year in America at the Angioplasty conference. Broadly speaking, there are two types of heart attack that we see. The big emergency heart attack we call ST elevation myocardial infarctions, or STEMIs for short. And they're the ones where we rush people to the cath labs, we put a tube in their wrist and we open up the blocked blood vessels that usually are the things that are causing them due to atherosclerosis, which is cholesterol plaque disease, rupturing and then becoming inflamed and then a clot forming on top. That's what normally causes STEMIs. What we found, we have a national database in the UK, and the Americans have a national database. The Americans have looked at their national database and found that in women, up to a third of their STEMIs did not have a culprit lesion on angiography. These are called MNOCAs, and they stand for myocardial infarction with no obstructive coronary artery disease. Now, we do see this. We have seen this before COVID, but nowhere near this level, nowhere near. Usually it's around 5%. 30% is just really unheard of. And it does make me wonder if COVID is playing a significant role in all of this. And that would again fit with the pathophysiology of what our researchers are telling us, that there's an endothelitis, there's microclotting, and there's obstruction at a microvascular level. And again, I think this needs looking at in further detail. And the other thing that so the other thing I should mention is it's not just this one paper. There's been a European Nature paper that has also found similar changes. And what I'll do is I can put them on my Twitter feed and you can have a look at them yourselves. So in addition to that, as a cardiologist, I have concerns that COVID is causing endothelial dysfunction, which is inflammation of the inner lining of the blood vessels, as I said. What we know is that traditional risk factors for cardiovascular disease include high blood pressure, diabetes, smoking, and high cholesterol. High blood pressure causes endothelial dysfunction. Diabetes causes endothelial dysfunction. Smoking causes endothelial dysfunction. You can probably see where I'm going with this. High cholesterol causes endothelial dysfunction. We know that COVID causes endothelial dysfunction. We know that endothelial dysfunction is the precursor to the development of atherosclerosis, which is the disease that causes heart attacks, strokes, and vascular dementia. So that worries me. And I think what we really need to know is whether the endothelial dysfunction caused by COVID heals by itself or not. And really, we need to be studying this, because if it doesn't, then I'm concerned that COVID is an independent risk factor for cardiovascular disease. And I'd be very worried that there may be the possibility that we're going to see a tsunami of cardiovascular disease globally in the next couple of decades. I don't know if that's the case, but I think we need to investigate further. And if there is evidence, then perhaps we should be treating COVID as another risk factor in the same way we treat high blood pressure, diabetes, smoking, high cholesterol with primary preventative therapy. But that needs to be investigated in a study first.
Thank you, Ray. I just want to let the audience know that we have opportunity for questions at the end of the program, so you can hold off on requesting, but we will look to elevate you after a few more topics are covered. But I have a special announcement from the World Health Network that have launched a long COVID resource today. We are working to get all of the information that is out there in little bits and pieces together in one place so it's easy to understand and clear. We're going to have a guide for clinicians also, because it's also challenging for clinicians to navigate the diagnostics on these emerging factors. We want everyone to be able to really understand thoroughly what's going on with their bodies, understand long COVID, and be able to help themselves, their friends, and their families. We even have some wonderful videos compiled of folks sharing their stories and what they've gone through, some personal accounts. And we also talk about all of the effects, not just on the body, but on society. There's so many impacts of long COVID across so many avenues. So ask you to mark down this new website link, worldhealthnetwork.global/long COVID. We'll be posting an announcement soon on our Twitter feed, so you can link to that. So grateful for all of the contributions from our experts team and staff at the World Health Network, and volunteers have been so dedicated in putting all this together. And we will continue to update it because this is an ever-changing situation. So we'll be constantly keeping up on all of the new developments so you have the best information at your fingertips. So let's move on now to talk about Omicron now, and how Omicron infections, how that relates to long COVID. You know, we've been breaking through this narrative, Omicron is mild, but we really know the data says it is not mild, right? So if we can talk about the risk of long COVID following Omicron infections, is it different? Is it the same? And what about constantly getting more infections on top of each other? How does that affect long COVID likelihood and the presentation of symptoms?
Hi. So my concerns is this whole narrative that certain COVID is mild, and if you're not hospitalized, your COVID is mild. I don't think there is such a thing as mild COVID, if I'm being honest. We don't know what the long-term effects of all of this is, and so I personally would err on the side of caution. With regard to Omicron infection, that's an interesting one. So there has been published data to suggest that on a individual level, on a person's individual risk basis, the risk of developing long COVID with a single Omicron infection is less than the risk of developing Delta. We have to have some good news somewhere. So in one of these studies that was from the King's College London, published in The Lancet, the risk of going on to develop long COVID with Delta was 10.8% and with Omicron was 4.5%, which is good because it's not as high on an individual risk basis. However, given that Omicron is far more infectious than Delta with a much higher R value, it's 6 times more infectious, and given that the peak of Omicron occurred after we decided to lift all the restrictions, it meant far more people were getting infected with Omicron. And so, although on an individual basis, you may be less likely to develop long COVID, if the amount of people getting infected is much, much more, then on a population basis, the increase in long COVID in the population is still substantial. And I think that's something that's really important to point out, because we have removed all mitigations. And although people may not be dying of the acute infection, it's not stopping individuals developing long COVID. Now, coming on to the reinfection data. So again, some of you will be already aware of this, but there's been a recent landmark publication preprint in Nature that has looked again at many people, over 38,000 that were reinfected in the reinfection group, and they've compared individuals who've had a first infection with subsequent infections. So they've looked at the health records of over 5.6 million people. And really what they've showed is that unfortunately your risk of reinfection increases your risk of dying, of hospitalization, but also increases your risk in COVID and lung problems and heart problems and digestive and kidney problems and diabetes and neurological problems. Now, again, if we go back to the pathophysiology I was talking about earlier, it kind of makes sense. If you have had a previous COVID infection, you've had a little bit of vascular inflammation and a little bit of microclotting, but not enough to cause you significant symptoms. If that is not fully healed and then you get reinfected again and you get a further inflammatory, immune and coagulopathic insult, then it's perhaps not surprising that we're seeing long COVID developing with repeated reinfections. It's not just adults. We now know that children also can get COVID, and we also know that the risk of long COVID appears to be increased in children that are reinfected, and the long COVID kids reinfection survey findings looking into that and to be published in full online in the near future.
Thanks, Ray. Can you tell us a little bit about the work that you're doing to support children's COVID consequences?
Sure. So both Claire and myself are medical champions for the Long COVID Kids charity. Currently, there are around 110,000 children in the UK that are living with the effects of long COVID. I'm a mother of 4 myself, and so it kind of breaks my heart to see these kids suffering like this, which is part of the reason I got involved. I think one of the problems is it's harder to diagnose COVID in children. They're less able to articulate what's wrong with them, and their symptom groups do tend to vary a bit with age. And I certainly know through my work with the Long COVID Kids charity that many families are really struggling to get help for their children and recognition and diagnosis. And there really is an urgent need to establish a robust biomarker for long COVID in children to help with this and to help get them the diagnosis and to help find them effective treatments. And again, I can't say too much publicly other than myself, other members like Benita Kane from our Team Clots research group are working in partnership with Long COVID and some fantastic paediatricians in the UK and overseas to try and make this happen. And there's a lot of work going on behind the scenes on a project right now, and once we are able to publicly talk about it, we'll do so. What we do know is that kids do get sick with long COVID, and like adults, this is not a psychological disease process, it is a pathophysiological process. So I've seen with my own eyes the activated platelets and microclots in the torn endothelium in the bloodstream of some of these children under immunofluorescent microscopy.
Thank you. Yeah, we want to say thank you so much to you and all of the volunteers and doctors with long COVID kids. It's such important work, and I know how hard you all are working to keep our kids safe and get them better.
So there was something else I just wanted to say with regards to the children, just if we have a minute, is that, look, we at first we thought, or we were told that kids don't catch COVID, we know that they do, and then we were told that kids don't spread COVID, we know that we do, and then we were told that kids don't get sick with COVID, and we know that they do, and we know that they can go on to develop long COVID. We know it's not to the same high levels across such a large population on first infection, but we also now know that the risk of developing long COVID increases with reinfection. We also know that in the xenon gas studies in children, even in those who've recovered from COVID infection without symptoms, that there's subclinical organ damage. We also know that long COVID causes endothelial dysfunction in adults, and we suspect it causes dysfunction in kids, and we need to obviously urgently study this. And we also know that endothelial dysfunction is the precursor for atherosclerosis and heart disease and stroke. So really, I don't think it is okay to allow children to get repeatedly infected with COVID at school, and I understand how important it is for our children to go to school, and I understand how important it is for their education, for their socialization, for their mental health, and their normal social and emotional well-being. And I'm not suggesting for a minute we do anything to stop that, and we need to get them to live as normal a life as possible, but we need to get them to do it safely. And one of the things about learning to live with COVID is about learning to live with it safely. So air filtration systems do not affect a child's mental health, self-esteem, emotional or social development. Air filtration systems in schools have clearly been shown to reduce the incidence of COVID outbreaks 12-fold in school studies in Belgium and Holland. So I really do believe that we need to urgently invest in air filtration systems in all of our schools to protect our children. Look, we wouldn't knowingly allow our precious kids to drink from a cholera-infected tap. So why are we knowingly allow them to breathe COVID-infected air? Our kids can't advocate for themselves, so we do need to advocate for them.
Absolutely. Thank you, Ray. That is such an important point, that it is certainly not in people's heads or in children's heads. These are real biological factors that are taking place that need to be taken seriously, that need to be acknowledged and validated and helped. And thanks to doctors like you and Claire and those at Long COVID Kids, we are making headway. We are making progress, and it will get better. But we all know that prevention is the most important, number one thing to keep ourselves safe, to keep our children safe, and keep ourselves protected. Can you talk a little bit about prevention?
Yeah. So what we know? What do we know? We know that SARS-CoV-2 causes long COVID. We know that it causes a risk of neuroinflammation and neuromuscular damage within the brain. We know that it increases your risk of clotting abnormalities like pulmonary embolus. We know it can increase your risk of heart disease. We know that we are seeing children who can get sick with this. We know that reinfection increases the risks. What we don't know at the moment is what the driver for all of this is, and what we also don't know is what the long-term health effects are going to be on the whole of our population, but also on our kids. What we do know is that SARS-CoV-2 infection is not and never has been just a cold. It is a CDC Level 3 airborne biohazard. Now, to work in a research lab with a Level 3 airborne biohazard involves restricted access, the use of negative air filtration systems, respiratory protective equipment, double glove, full PPE, and the medically vulnerable aren't allowed to enter. By comparison, to work with the same Level 3 airborne biohazard in, for example, the A&E in some of our local hospitals now, you don't even need to wear a mask if it's airborne. You do need to wear a mask if you know they've got COVID, but it may well be in the air. I struggle to work out why there's a difference and why we're not having more public health measures in helping to control this. Prevention is most definitely better than cure in this particular situation. And I think one of the things I would like to just touch on, I suppose we can use the analogy of the cars. As long as there are cars on the road, there will be car crashes. That doesn't mean that we should lock ourselves away or lock our cars away and not use the roads, because that would be ridiculous. But neither does it mean that we drive an unsafe vehicle without an MOT or a service history at any speed, in any direction, on any side of the road like a toboggan, without seatbelts or airbags or rules. We would never dream of doing this, and we would never dream of letting our precious children travel without a safety seat. So we mitigate the risk by putting in safety measures, the highway code, MOTs, seatbelts, driving tests, and we see that infringement of our civil liberties, and we all accept that this is what we need to do to keep ourselves safe. So I agree that we need to learn to live with COVID, but we need to learn to live with COVID safely. And to do that, we need a big grown-up conversation about public health policy and safe and sensible mitigations. Without that, and things, for example, negative air filtration systems, HEPA filters, masking in crowded indoor spaces, and without those grown-up public health conversations and discussions, learning to live with COVID is like a car crash waiting to happen.
Thank you, Ray. I would like to remind everyone that we have our long COVID resource and other information available on our website, worldhealthnetwork.global. If you've missed any of this talk, you can watch or listen to the replay rather here on Twitter Spaces. We're only listening. And you can join us also. Our World Health Network contact us is available, and we would love for you to join our network. So thank you so much, Ray, for this thorough, comprehensive information. I think folks are really going to appreciate knowing what tests to ask for and to have a better understanding of what is going on inside the body to take the prevention more seriously. So now we're going to switch over to Dr. Claire Taylor. Claire is a general practitioner in Scotland, and we would love to hear a little bit more about your background story, how you got started working in the field of long COVID. Claire. We're going to take 1 minute. Claire's getting ready. Oh, she's ready. Okay.
Hi, that's my icon. Hi.
All right, perfect. Thanks, yeah. Claire. Welcome.
Welcome. Thank you. So yes, my long COVID clinic has naturally evolved from already having pre-existing knowledge of diseases of the immune system that we don't really understand very well, and all of the emerging research that's come since then it was natural to put what I already know to work now, because a lot of what we've talked about with microclots and such are still being heavily researched. And we have really sick patients at the moment who I couldn't help apart from my own NHS GP surgery. They were the only patients I could help. And even in a small surgery of sort of 5,000 patients, had quite a lot of long COVID patients. But I was starting to get requests from other people and from actually members of staff in my area looking for advice on their patients. And so I thought, let's see what we can do with what we have at the moment. And as things come forwards, which they will, because we've got a lot of dedicated people, including Team Clots and people like Amy Pro looking at viral persistence, other groups, looking at autoimmunity, well placed to put that into practice. But for the moment, I actually have patients who are extremely sick, and often I would agree with Ray. Even the word having long COVID seems to then cause people to switch off and then not do the investigations that would have been done normally before COVID. So we've sort of accepted that people going about with oxygen levels, 80% during their normal day, we've sort of accepted that, well, that's just COVID, or that's just long COVID. And actually that before the pandemic you would have had a robust, quick workup for that. So, I'm currently trying to even just work out the basics with people and make sure everybody have had the basics of what you would do with any disease presenting like that, before even progressing to the treatments that we already have. And as already touched on by Ray, one of the conditions that we see really prominent in long COVID is postural orthostatic tachycardia syndrome, and I'm going to just call it POTS from now on because that's a mouthful. And the other syndrome that we see is mast cell activation syndrome, first described only in 2007, so although it's probably been around for millennia. But knowing how to treat those at the moment seems to be helping a lot of people, and knowing how to rule out other diseases, actually sometimes finding other diseases alongside the COVID, or that it isn't long COVID, is all really important work.
Thank you. Thank you so much. Your work is so important, and we're so appreciative of doctors like you that are dedicating. We know it is so much. It's draining, it's hard, but you are so needed. So thank you for your dedication to this troubling disease. So in your experience at your long COVID clinic and clinical practice, besides the cardiovascular symptoms, you've seen mast cell activation syndrome, you've seen chronic fatigue. Can you talk a little bit about this?
Yeah, so I see different types of people. So I will see people who are very potsy, and I'll talk about in a minute about testing for POTS, but I can almost tell straight away if somebody's got POTS just by their symptoms, and they often have neurological symptoms alongside that, and describe themselves as buzzing, as feeling like their bodies are buzzing. And I have another group who are straight up fatigued, just absolutely bone crushing fatigue, and then another group that can they all sort of cross over, but this sort of allergic type symptoms, multi-system symptoms. So I have different sorts of patients, and when I first see them, I've got to make sure that their initial tests have been done. So if somebody's bone crushingly fatigued, they've got to have a morning cortisol to make sure they don't have Addison's disease, and even that sometimes it hasn't been done. Sorry.
No, it's okay. I just wanted to, I'm not really that familiar with POTS. Yep. I know that everyone is. Could you explain a little bit more in detail, what POTS is?
What POTS is? Yeah, no problem. So I aim to rule out other things, and then I can be, once I'm sure somebody has got POTS, I will diagnose them with POTS. So what is POTS? So to put it in simple terms, it's when the heart rate goes up by over 30 beats a minute within 10 minutes of standing, without a drop in blood pressure. So that would be your typical, you know, if you look it up, that's the definition. And it's not quite as straightforward as that, because we often have patients that would fit more into what you would call a dysautonomia, which is just a broader term for things that affect the autonomic nervous system. So that's involved in all of your normal bodily functions. So you know, it keeps you alive. Your autonomic nervous system keeps you alive. It controls your heart rate, it controls your breathing, it controls your blood pressure, it controls your digestion, your sleep, how much you sweat, your body temperature, your bladder tone, and clearly, if that system isn't working properly, and whether you class that into POTS and this, you know, criteria of pulse going up 30 beats a minute and blood pressure not dropping, or whether you're talking about a spectrum of people that might go up 25 beats a minute, for example, and they might feel horrific, you know, and have symptoms associated with it, you know, we might still think that's somebody within that group. But essentially, these automatic things, a bit like when you start your car up, and everything should just come on. Everything should just work. So when you turn your car on and it doesn't work, you want a mechanic to work out what bits aren't working. And you know, there isn't always a really clear delineation in autonomic disorders, but that automatic part of the body isn't firing right. And the autonomic nervous system is split into two pathways: the sympathetic side and the parasympathetic side. Apologies, I did not name those systems. But to try and make it a little bit clearer, the sympathetic nervous system is your fight or flight. So as I've already said, you need your autonomic nervous system for survival. So fight or flight, clearly, if there's a lion turns up in your room, you're going to need to be quick out the door. And that's your autonomic nervous system that gets you out the door, the sympathetic side. The parasympathetic side is the rest and digest side. So the opposite. And there should be a bit of a balance between those two, so that you don't have too much adrenaline and fight or flight, or you know, sitting there with a pulse really, really low because your parasympathetics kicked in too much. And lots of things can disrupt your autonomic nervous system, POTS being one of them, where your pulse goes up by 30. You can also get inappropriate sinus tachycardia, and Ray mentioned that, and that's just when your heart's racing all the time. It's always above 100. So normal would be roughly between 60 and 100 beats a minute. Some really fit people have got a little bit lower than that, but generally that's what we would call normal. And testing for POTS. So there's two ways of doing it. One of them is a tilt test. Strap somebody to a table and tilt them up and see what happens. Quite often people will faint and feel absolutely horrendous because the blood isn't pumping up against gravity. Their heart will then compensate, and you'll get this fast rise in the pulse. Certainly in Scotland, we're not really seeing very many tilt tests. They were stopped with the pandemic due to restrictions, and don't seem to be restarting. And down south in England, there are some still happening. However, the stand test, given the numbers of patients we've got with POTS now, the stand test where somebody lies down and rests for 15 minutes and does a blood pressure and a pulse, and then stands up leaning with shoulders against the wall and does the same for 10 minutes and does a blood pressure and a pulse every minute, that will give you a decent reading of what your pulse and your blood pressure are doing. If your blood pressure crashes, you're on that scale, but you've got a postural hypotension. So you can find out quite a lot by a stand test, and it's easy to do. You only need a blood pressure machine. And there was a paper out by Prof Mathias last week about home autonomic testing, and that it might actually reflect better what people have at home. So they might come into the clinic and have a lovely pulse, might be sitting at 70 and they look fine, and often that's why people are told, well, there's nothing wrong with you. And actually, if they go to A&E with the symptoms and they have an ECG done, it's a normal rhythm, it's just a little bit fast, so you must be anxious. Actually, what's important is, what symptoms are people having? Is it disrupting their lives? And once you've got some idea of what's going on, is trying to give them, first of all, lifestyle advice to try and help with that. And then if that doesn't work, is medication. And there are thankfully, medications that can help to bring POTS under control. Because if you were to go to work today, so this is for the non-POTS people. So the POTS people probably know what I'm talking about, but the non-POTS ones, if you imagine you're at work today and you're sitting listening to this and you go to stand up or move and your heart rate's 160 like you've just been for a run. And then imagine that happening all day long every time you try and do anything. And then imagine how exhausted you'll be at the end of the day. That's POTS. And it's a very debilitating condition. And in fact, the quality of life scores are as low as heart failure. Yet we do not give patients anywhere near the support heart failure patients get anywhere near enough attention by medics. And in fact, some medics still don't know what POTS is. So I hope they're listening.
Yeah. Thank you. So I'm hearing some people on social media talking about numbness in their hands and their feet. It's related to COVID somehow. Might you be able to explain how that's all related and what's going on there and what's that called?
Yeah, so there's lots of conditions can give you those sort of symptoms, but sort of relating into about a third to half of POTS have got a small fibrin neuropathy. So it's important that if you do have sort of burning pain in your hands and feet, or numbness, or you can't detect temperature very well. So, for example, if you go in the shower and it feels hot instead of cold, and it's the opposite way around, that you have a full workup to work out what's going on. But actually, small fibrin neuropathy is another one of these conditions that we don't know an awful lot about, but we know that people with POTS get it. We now know that people with long COVID get it. People with ME get it, and having blood tests, a raft of bloods really to rule out any other cause of nerve damage is how it's approached. And then often what will happen is all of the bloods, as we've talked about already, all the bloods will come back normal. The B12, the folate, the thyroid, the usual will come back normal. And at that point, depending where you work, if you're considering a small fibrin neuropathy here, and so a small fibrin neuropathy is damage to the peripheral nerves, so far away from the spinal cord. So predominantly, hands and feet, so the long fibers, and it's like almost when they're damaged, like it's the end of a cigarette burning up, is how people would describe it. And it usually affects the small fibers, which are either lightly myelinated or unmyelinated, and myelin protects your nerve fibers. So if you've not got a lot of myelin around your fibers, they're much more prone to damage, whether that's by viral insults, infection, inflammation, and it can affect the sensory parts of your nerves, but also your autonomic nerve fibers. So it ties in with POTS and affects your autonomic fibers. You can get non-length dependent, which is not affecting your hands and feet in places like your trunk and your face, and that's more unusual, but people need to know about it. So if somebody's complaining of really weird symptoms, they're not crazy. A patch of this or a patch of that. Actually think about small fibre neuropathy. Investigations, so you can do the skin biopsy, and that's positive in about half of people. To my knowledge, any patient I've ever had through my clinic that's been seen by a neurologist has never had a skin biopsy. You can do quantitative sensory testing, looking at the change in temperature sensation. None of my patients have had that. So it seems to be more common, because usually a neurologist would diagnose this. It seems to be more common that there is a history of these symptoms, and then an examination, and then ruling out another type of nerve damage, and then calling it small fibrin neuropathy. And actually, I've often tried to refer people in with this, and I've been told there's no point, because we don't know what causes it, and there isn't any way of preventing it. So, but I think actually it's worth talking about, because these sort of symptoms really bother people. They worry people. So, if you go on to Google and you Google symptoms like that, you might come up with things like multiple sclerosis, and they need to be ruled out. But actually, if you've got nerve symptoms and you don't know what it is, and actually you're not being given a diagnosis, that's actually really important that you're given the diagnosis. And I'd like to see more investigations done to say this is what it is, and if it is a skin punch biopsy, then it is a skin punch biopsy. And you can do an epidermal nerve fibrin density biopsy. They're 90% specific, minimally invasive, easy to do. Our healthcare system's under huge stress, and imagine across the world. What I'm reading is that, we're talking about living with COVID, but our health system seems to be at winter levels already in August. I think across the world we're still dealing with waves of COVID. Our wave is coming down. However, it was the third one this year, and it is only August. So it might not be easy to get tests for these, but I think it's very prevalent in long COVID. Just a little word about Sjogren's disease. It's an autoimmune disease. It causes dry eyes and dry mouths, and it can be a cause of small fibre neuropathy. Blood test for that, but it's not always specific. And it's important if you've got a small fibre neuropathy to rule that out. Sometimes I see people and I'm not quite sure if they're on the way to developing an autoimmune disease and aren't there yet. But it ties in with POTS. As I said, there's a crossover between POTS having small fibre neuropathy. Most of the time we label it idiopathic, which means we don't know what caused it. However, I like to label things post-COVID. So if I see somebody after COVID, I would call it post-COVID small fibre neuropathy rather than an idiopathic. And there obviously needs to be more work into that too, like everything else. But yeah, just an awareness for doctors that this condition exists, that we don't really do all the tests that we can do. We could do better. Treatment wise, there are medications that can help with the symptoms, which can be really troubling. Interestingly, what we do see on biopsies doesn't always correlate to how much distress somebody has. So you could have somebody with an awful biopsy who's got not too much pain or bother, and somebody with small changes who's driven demented with it. Important to know that there are medications, generally of the groups, off-label ones that have been repurposed, the anticonvulsants particularly, that are now being repurposed for chronic pain and that sort of thing, can be really helpful with that.
Thank you, Claire. It's really helpful for us to understand these symptoms that are emerging. People might not realize it's a result of COVID. Like you said, they might think it's something else. So it's important to differentiate. I just would like to let the audience know that if you had a question for Ray or Claire, it's a good time now to request to come up and ask your question. So I'll ask those of you interested to go ahead and request now, and we'll get folks queued up. But before we do that, we're going to have a final chat here with Claire and Ray, and just to summarize how best we can help people with long COVID. I want to start with Ray. Or Claire.
Okay. Sorry,
you're there.
I'm still muted. So I think the first thing to say is that we, and when I say we in the medical community, we have to, and a lot of people are now, but we have to stop gaslighting patients. We have to realise that this is a pathophysiological disease condition that is making people very sick. It is not in their heads, it is not anxiety, it is not deconditioning, it is not being unfit. So we need to recognise it. And then we need to actually investigate it properly. And we've given you a list of tests that are available now that can be helpful. And there's a list of tests that we are hoping to develop that would be helpful in the future. Once we've got the diagnosis, there are treatments that we can give, and there are treatments that we are working on. So the treatments that we can give are treatments for dysautonomia and POTS, treatments for MCAS, treatments for complications of COVID, such as myocarditis and pericarditis. The treatments that we're working on is studies looking at potential therapeutic targets for the whole inflammatory endothelialitis, microclotting coagulopathy, which we are hoping to test in some research studies. There's already evidence in some countries that are showing some good results with this using certain repurposed cardiovascular medicines. I think it needs to be probably a combined protocol. It absolutely has to be done safely and supervised, and we're looking at studies to try and look at the safety of using some of these drugs in a repurposed way to see if we can improve the symptoms of patients living with long COVID. But the other thing we need to talk about is trying not to catch COVID in the first place.
Yeah, so I think yeah, going forwards with long COVID patients. So we've obviously got a couple of million people, so it's went up 1 million in a year. So we've added 1 million people with long COVID, and actually heard it being downplayed the other day that we've overestimated long COVID because things like headaches are common, and sort of standing up to that and saying, well, wait a minute, no, we're not. We've got a really good survey in the UK that looks at long COVID, and we're probably we're probably underestimating it. And then I think acknowledging how many people have it, then we have to acknowledge how sick people are. We have people who are bedbound. We have people who cannot stand up. We have people who have lost their jobs. They've lost everything, and they have waited around for a couple of years. They've been passed from pillar to post. They have been told there's nothing wrong with them. They've been told their tests are normal, and now look at the research on the vascular side of it. People have got an endothelitis. They have got inflammation in their blood vessels. They've got an immune system that doesn't work properly. They've got an autonomic system that doesn't work properly. And I think even if you don't know as a doctor exactly what's wrong with someone, you don't know exactly how to fix it, acknowledging that that people are really, really sick is so important, and doing it early on, the first time you see them, and making sure you rule out the big things like a blood clot. Rule out a blood clot if somebody's got a raised heart rate and you're short of breath. Rule out inflammation in the heart. Do all that stuff, and then I didn't get much time to talk about mast cell activation, but I'll put it on my Twitter. There's various ways of managing that and diagnosing and managing that, and I think doctors are becoming more aware of these conditions that sound mysterious. They aren't actually that mysterious. They're really prevalent, and they explain a lot of multi-system symptoms in people who look like they've got normal results. And think outside the box that normal results might mean you're doing the wrong tests. Normal results might mean we haven't actually made the test yet. There's a really good film called Brain on Fire about a lady that became very unwell, and she was one of the first women, first people in the world to be diagnosed with this condition. And I won't say what it was to give it away, but it's on the same theme as this, and that sort of demonstrates that sometimes the test isn't even developed, and all the people before that test got told that there was nothing wrong with them. So, and I think lastly, what I would say is, the ME patients who have been sick for a long time, and where we have learned a lot of our trade on treating POTS and MCAS, and we also know about vascular problems and cortisol problems. We need to take them forward with us in the research. So I think the research from long COVID will have an effect on all diseases, and can only echo what Ray says. We don't know the long-term effects of this. If my kids have had it a couple of times, I have no idea what their blood vessels will look like by the 10th time. And I don't think anybody does. I don't think anybody can say with absolute faith that it is not causing long-term problems. I can't either, but I would be cautious that it is a vascular disease.
Thank you so much, and thanks for all of you that are interested in asking questions. I've got a few people on deck here, but before we move to that, I'd like to ask Yanir Baryam, co-founder here of the World Health Network, complex system scientist, pandemic expert, to add a few comments here if you are there and available. All right, maybe Yanir is not available right now, so we'll get back to him. So Yanir, go ahead. I think Yanir might be having some technical difficulties there. So that's fine. So Yanir's going to sign in and sign off. All right, so let's move to Claire. Claire Rayner, would you like to ask a question? Thank you.
Yes, thank you. Really, really helpful and informative talks. I find that people up high, and I had a meeting with some very senior people today, and we were talking about the need for prevention for workers, and the attitude was very much, well, the pandemic is over. Why have we got to bother continuing with protections when people could get this anywhere? Oh, Claire, I was going to ask you why you think it's absolutely essential to continue with protections, which obviously I do think we need to do, but why, in your opinion, what you're seeing?
Well, I think for me, the number one reason is we have absolutely no idea what this virus is going to do next. So the virus is doing its own thing, it's mutating, and we're not really keeping the track on it we kept on it in 2020, and it's mutated a lot since the wild strain. And we get these big announcements when there's a new strain. Is it going to be worse, better? Is it brilliant news? Is it not brilliant news? We absolutely just don't know if it might mutate into a strain that we don't need to worry about, or whether it might be something worse. And I think it's too early, although it feels like a long time, and it is a long time that we've been dealing with COVID. It's too early to say what it's going to do next. And we already know that it's causing problems with people's blood vessels. We're still trying to work out if that's a long-term problem. We know the risk of heart attacks and strokes goes up in the year after COVID. Even if you've had a really mild version of it and you've recovered, your risk is still up. So then if you get COVID twice in that year, or 3 times in that year, then what is the risk? And I think until we can find these things out, we need to make sure that we're not taking our finger off the pulse. And for me, when I go to anywhere indoor, I wear an FFP2 mask, and I don't find it onerous. And having had COVID a few times myself, I don't know which infection could be the one that gives me long COVID. So I'm erring on the side of caution, knowing all that I know. And I think until we know more, or something changes with this virus, I think we just need to err on the side of caution. It doesn't mean closing everything down. It doesn't mean not doing anything again. We can put air filters into schools. We're not doing it. We can put it into offices. Why are we not doing it?
Yeah. And you and Ray have so brilliantly explained the awful sort of problems that you're seeing with people. Thank you so much for that.
Thanks, Claire.
Thank you, Claire. I've elevated quite a few speakers, but if you're not, then if you could stay muted, that would be great for everyone's audio experience. So Yunir is back on, so I'm going to turn it over to Yunir now for a few comments. Thank you.
So I wanted to take a moment and reflect at the sort of largest scale picture. There is a picture that has been developed about how diseases affect us as individuals. And that is, let's call it a textbook immune system response, where you get a disease, it's possible that you will die, but if you don't die, the immune system has defeated the disease, the body is repaired, and everything is fine. What we're hearing is that this idea is not working in the context of COVID. Instead, one of the key things is that the immune system itself is damaged, is harmed, as well as the systems around the immune system, particularly the blood vessels and the other things that the immune system interacts with. And so the underlying structure of the body, rather than just the time during which the original infection occurs, is actually directly impacted. And there is also, of course, some damage to the body that has happened that the body can't repair, partially because of the immune system being damaged itself, and that would be playing a major role in the repair process. But there may also be things that even the immune system cannot repair in the body. So part of the point is that this basic picture that if you haven't died, you are okay, is not describing the aftermath of COVID infections. And even the people who don't have symptoms of long COVID that are generally recognized may have, in fact, have been shown to have organ damage and immune system damage that can accumulate and become worse with progressive infection. So just this contrasting this textbook idea of how diseases affect us and immune system can be either fail or be victorious with the reality that the body and the immune system themselves can be harmed in a way that persists. And our responsibility is to recognize this, both from the point of view of the importance of prevention, and now with a major percentage of the population, indeed a wide-ranging presence of both symptoms and even more the presence of the underlying damage, we have to understand how we might be able to help people by recognizing it, by helping them in the consequences of it in their lives, and also in the potential for improved medical intervention to reduce those effects.
Great, thank you, Yanir. And I just want to remind everyone, maybe some folks just signed on, this talk will be available for replay. And we also have a new long COVID resource up on our website, worldhealthnetwork.global/long COVID. So you can get the most up-to-date information. As I said, we're going to be monitoring the developments, the research, the treatments. It'll all be updated there in one place, easy to find and access. So please look forward to checking that out. So thanks everyone. I've elevated quite a few speakers and we'll start to go through. Thanks everyone's patience. I know folks have been waiting here for quite some time. So Professor Sunit, you can go out next.
Thank you, World Health Network, for giving me platform to share my views. So I am having few very crucial points here to share with, and I think I would also raise few questions which if anyone can answer. So as Yanni already talked about the immune system and SARS-CoV-2. So I would say, in reference to viruses, there has been always a cat and rat race in between virus and the host immune system. And if we go little back, we will see that in the case of HIV, it was there and it is still there, where HIV latency is the biggest problem which we could not tackle with. Although with the advent of antiretroviral therapies, we could extend the life of the human being for a few more years. Now, if we talk about the SARS-CoV-2, here also things are being reported that viral RNA persists for 6 months to years, and in few cases even I have gone through some of papers which I don't exactly remember the references, but yes, they say that there is possibility that a live virus might still exist there. So a kind of situation of latency is being mimicked over here too, but unless and until it is proven that there is a latency in the SARS-CoV-2, I would certainly restrict myself in saying that it is the exactly same latency as in the case of the HIV. Now, the microclotting case, where means if I just say endothelitis, where endothelium interacts with the virus and gets inflamed, and I have come across a literature where microclots, and these microclots are exactly not resembling the normal clots. What happens in the normal clots, fibrinogen gets converted into the fibrin with the help of enzyme thrombin. But here, what is being seen, the conformation of fibrin itself is very different from the normal fibrin. So now it's being reported that something is happening at protein level where it is changing the conformation, and if we can equate this condition, then we can equate with the prion diseases if we go back. Now, my last I would like to here share, I am not sure that how many times our immune system will be able to cope up with the inserts of various variants and subvariant. Only my concern, suppose in either a person is suffering from long COVID after Delta or even the Omicron, if these variants are going to repeatedly infect a person who has been earlier infected, so I think situation is going to be really very difficult to handle, and the microclotting and other, I recognize this COVID-19 as a multi-organ system disease. So it's going to be really difficult. And if there is any viewpoint of anybody who could a little bit share how to manage these situations in future, that would be great to listen. Thank you. Highly appreciate it.
Thank you so much.
Okay, thank you. So I have to say I agree with a lot of the things that you were saying there. I think all of this is occurring. It's a very complex interaction. Like one of the things I'd said at the beginning of the talk is the bit of the jigsaw puzzle that we don't understand. We're beginning to understand the host response to infection, and as we said, that's immune inflammatory mediated with immune abnormalities that's then triggering endothelitis and platelet activation and activation of the coagulation cascade and the formation of fibrin amyloid microclots. So we've kind of put all that bit together. I'm sure there's more that we need to learn, but you're absolutely correct. The bit that we haven't worked out yet is the underlying driving factor that's the cause for this chronic inflammation that we're seeing. And at the minute, currently I think there are 4 hypotheses for what that could be. The first, as you quite rightly said, is the ongoing immune activation and vascular inflammation from long COVID is due to persistent viral infection, persistent viral reservoirs, possibly in the gut. Now, that's not really my area of expertise, and that's not the area that I'm researching, but we do have fantastic researchers like Amy Prohl who are doing loads of work in this field, and I think it'd be really interesting to see some of her results when they come out. The other option is that it's not live virus that's latent, but it's actually persistent viral antigenic material in the bloodstream, for example, spike protein fragments or nucleocapsid fragments that is driving this chronic inflammatory process. And that's certainly another possibility as well. And that perhaps explain some of the similar changes we are seeing in a small percentage of individuals who get similar symptoms to long COVID following vaccination. Other that could it just be that the degree of tissue damage in the blood vessels is so bad itself that if the endothelium is unable to heal, it just keeps re-triggering and re-triggering and re-triggering the whole chronic inflammatory process? And that's another possibility. And then the fourth hypothesis that is ongoing at the minute is that we start off with a situation where we have autoinflammation and immune inflammation, and because it's ongoing and the immune cells are trying to overcome whatever it is in the bloodstream that's driving it, the damage, the ongoing inflammatory process results in a transfer from autoinflammation to autoimmunity down the line. And does this eventually become an autoimmune disease in some? And we don't know that yet. We have found autoantibodies inside some of the fibrin amyloid Rhesia pretorius has found some of those. There have been autoantibodies found directed against G proteins, means, but it's a really important question, and actually it's a vital one really, because until we work out what the driver is, that will depend on what our potential treatment targets is. So for example, if there's lots of chronic inflammation, a potential treatment, as well as treating the coagulopathy, which I think is something that we most probably need to do, but we need to test in a trial, is whether immune mediators to reduce the inflammation would be useful. But I guess you don't want to immunosuppress somebody that's got live virus floating around. So we really do need to understand more. I agree with what you're saying.
Thank you, and thank you, Dr. Sennett, for your question. All right, so we're going to move to someone who's been very patient, Azilith. Thank you for your patience today, and you can go ahead with your question.
Hello, I just wanted to hopefully offer a little hope and highlight something of interest that could potentially take place in local government. I've been working closely with a councillor, and they're planning to raise a motion in the next couple of months to have HEPA air filters rolled out in schools. And I just thought, offer a little bit of hope, because obviously, there's a lot of unfortunate things that we're discussing. So just advise people, keep an eye on Edinburgh just to see if that's successful in the next few months.
That is wonderful.
Hallelujah.
Wonderful.
Amazing. Thanks for letting us know, and we'll keep an eye out for that amazing work. Thank you.
Thank you so much. We love the good news. We love the good news. And I also want to acknowledge there's a lot of folks that are requesting to speak. We have another event coming up, so there'll be more opportunities to speak to these experts and other experts in our long COVID group. We're going to be having a symposium coming up, so look out on our Twitter posts for this announcement. We're very excited. We're putting together an afternoon event, so something to look forward to there. All right, so let's move to Harriet. Go ahead with your question if you're there.
Yeah, thank you both to Claire and Ray for talking today and for all your advocacy. On a personal note, I want to thank Dr. Ray Duncan for advising my doctor to get me a VQ scan, which I feel like has saved my life because they did find multiple pulmonary emboli, which meant I got the right treatment. So thank you, Ray. My question is really, how do we convince doctors to think outside of the box? I mean, my breathlessness didn't start for about 7 months. Most of my tests are normal. How do we convince doctors to do the tests? My radiologist initially kicked back the VQ scan, and it was my doctor, luckily, who fought for it based on Ray's advice. So yeah, how do we convince doctors to do these tests when it goes against all other guidelines?
So I think we change the guidelines. That's the simple answer. We change the guidelines. It's a new illness. The rules do not apply in the way they did. If the rules aren't working, then we change them to rules that are working. And it's all about education. And one of the things that I think I'd like to say, and actually she's just asked a call, hopefully still, is that Claire Rayner is, who asked a question earlier, is actually a fairly prominent occupational health physician in the UK who has been a wonderful long COVID advocate and has recently written a fantastic paper from the Society of Occupational Medicine, looking at how we should be investigating and treating and managing individuals with long COVID, not just from the medical side, but also in how we get people with this chronic disease back into work, what reasonable workplace adjustments we should be making, how can we help them from all aspects of their life, not just the medical side. And that's something that's just been published recently, and I was very pleased and delighted and honoured to be asked to help contribute towards that document. And I think that's a document that will be extremely useful, not just for the working in the field of occupational medicine, but for all departments working across the NHS. And doing more events like this, where we're trying to educate and teach people what we've learned in our own clinical practice, I think is also going to be helpful.
What I would say actually is that guidelines are not tramlines. They're just guidelines. So Harriet, you telling us your story about your clots. A lot of my work at the moment is trying to convince other doctors, like you had to, that somebody needs a scan for blood clots. And what I've been looking at recently is our previous scoring of blood clots would involve doing what's called a Geneva score. So you would put in somebody's age, you would put in any pre-existing blood clot factors, like having a broken leg, anything that elevates the risk. And if the risk comes back as high on that scoring, you just scan them. And if the risk comes back as low, you do a blood test. And actually, is COVID one of the biggest risk factors? And do we have to change the pre-existing scoring calculators so that if a doctor uses their normal scoring pathways, which they've done for 20 years, if they put it in, actually it comes out saying actually your patient's high risk and they need a scan. So looking at pre-existing practice and how it needs to change post, and in COVID, how we change it while we're dealing with COVID, so that you can't be blocked back saying this doesn't fit our guidance. And I think, as Ray said, doing events, and I think most docs are interested. Everybody's working really hard in the NHS, and there's trying to keep it going, keep managing the daily workload, and I think just chipping away that and reminding people that it's a new disease and that we need to be open-minded, and medicine is an art as well as a science.
Thank you. All right, let's move to Nick Boeing.
Hi. My question has to do with getting booster shots, and I'll give you just a brief background. I probably had COVID in March 2020, but I didn't qualify for a test at that time, so I'm not sure.
I just want to interrupt you, get going. We can't answer any direct medical personal questions.
Oh, okay.
Yeah.
Yep. Then in general, if someone has had what seems to be, or if somebody has developed long COVID, possibly from getting a booster shot of Moderna or mRNA, is it likely to do more harm or more good to get further vaccines, or possibly a different vaccine than mRNA, like a Novavax? I don't, if you can't answer that, or if you don't feel comfortable answering that question, that's fine. Move on.
Okay, thank you. Unir, do you have a comment for this?
Yeah, I think that one would have to know more about the specific circumstance. Someone would have to do an evaluation. Clearly, we do not know exactly the interplay between different things at a population level. So I think we would have to defer that question and recommend consulting with a appropriate physician. And if you need someone to look to in the long COVID resource that we put together, there are various groups that are local groups that may be able to connect you with physicians in your area.
But yeah, thank you for your question and understanding that we can't comment on specific medical advice.
Of course.
Best of luck to you, and thanks for calling in.
Thank you.
We welcome you to join our network. Thank you. All right. Long COVID advocacy. Do you have a question for us?
Yes, I do. Just first of all, thanks for giving space to discuss long COVID. And this is actually about trying to help people get the tests that they need. Ray and Claire kind of gave a really good summary on like the diagnostics that are available at the moment. But it's still difficult when patients see a doctor in a 10-minute appointment or even a clinician in a long COVID clinic to receive the most appropriate tests. And even if you go with your research, and there was a really good paper in the British Journal of General Practice about tests, but I was wondering if it's possible for some long COVID specialist doctors to collate like a really short resource of tests for the different like sub-diagnoses of long COVID that you can hand to your doctor that would help kind of give authority to the request. And so it's more cognitively easier for patients to do that.
Yeah, I think that's a really, really good idea. If you have a look at the Society of Occupational Medicine paper that I was just talking about, there is a medical appendices section at the back that actually does that to some degree. So have a look at that, because I think that would be very useful. But yeah, I think that's something that we probably need to sit down and put together a document where we think these are things that in our own clinical practice we've found helpful. I think that's a really good idea.
That would be great, because I know patients are going to their doctors with research papers, and they're kind of up to date with it all. But sometimes the doctors aren't, and you kind of actually just need like a flashcard for them to just like really to kind of so they can get the information quickly. But yeah, that would be brilliant if that could happen.
Yeah, at the moment, the closest we've got to that is the Delphi paper.
Yes.
But you're right. It probably needs to, most doctors will look at the NICE guidance. So the National Institute of Clinical Excellence, or SIGN, which is the Scottish version. And actually, I don't think it's as comprehensive as it should be. It's probably outdated now. And when these things are written, it depends on people's expertise who are writing them. And I think perhaps bringing together, now that we know who is most up to date in the country on long COVID, maybe bringing them together to write a guide is worth doing, and it's something we've talked about in the World Health Network, is getting something up on the website. One thought was 10 things that we think every doctor should be aware of, or just summarising papers is useful, but actually having something that patients can give to a doctor that the doctors understand. I'm doing some talks to doctors in the next couple of weeks. Done some recently, so I think you can, local level, you can chip away. And my clinic's fairly new, so I'm getting lots of queries back from GPs about what's this or what's that. Never heard of this. Never heard of that. So I just give them a ring up and say, have you got 5 minutes to go through what this is. You might not have heard of it. But yeah, we will try and get something put together. You're absolutely right. And I know how stressful it is for patients who go into a doctor with something like mast cell activation syndrome, and the doctor is just can end up a very dysfunctional appointment where they don't feel believed, and the doctor doesn't know about it, which is not, they don't like that feeling either, and then it doesn't work. So I think we will try and get something up in the next couple of months for patients to take.
Great. Can I just ask one more question related, actually, Lily? I mean, are any of the kind of Team Clots doctors and people who are kind of leading the way in the UK in conversation with the NICE team and the NICE guidelines, because there's definite work to be done on the long COVID guidelines, especially with evidence reviews and things. And it would be really nice to kind of connect those dots.
But I don't know, I'm not on it. Is Ray, are you anything?
Yeah, so actually, as part of my remit with the long COVID kids, I've been involved in feeding back into the NICE appraisal on COVID and long COVID. So I've just submitted some stuff for that.
Brilliant. That's good to hear. Okay, thank you very much for your time. Bye. Bye.
Thanks for calling in. All right, we have a couple more questions here. VZ, go ahead.
Thank you so much. First of all, I want to thank everybody who has participated in sharing expertise and information today. I'm just a mom from Toronto, Ontario, Canada, listening and trying to learn. I think that a lot of what's been shared today is information that people who have long COVID end up needing to learn about in order to access care. My family, we have been fortunate to be able to avoid COVID so far. And the thing that I feel concerned about is having this information accessible, in sort of layman's terms, like that anybody can understand. Why do we need to protect ourselves from getting COVID in the first place? So that's something that I think a lot of people don't know. And long COVID is something that someone else gets, not something that I get, that sort of thinking, which it sounds like that is going to take us down a bad path. And has done. The thing that I specifically wanted to ask, I think that Ray mentioned a study that she was able to speak about that related to microclots, and that people who had long COVID had a significant number of microclots, and that others who had COVID but hadn't been diagnosed with long COVID had some microclots. I wanted to know what percentage of people who had COVID but were not diagnosed as having long COVID, what percentage of those microclots, was that something that was more prevalent in certain demographics? And is that something that sort of resolves over time, or when people get COVID another time, they sort of get more microclots? I mean, I guess this information will...
Oh. Hello?
Sorry, my husband's calling me. I just hit decline. So I'm just curious about that, and if there's more information that's available, or when that study will be coming out.
Okay, so the study at the moment is ongoing. We can't give too much information out about it. The numbers are still relatively small, so we're still recruiting more patients. It's being run by my colleague, Associate Professor Caroline Dalton, who's doing a fantastic job and has given me permission to share some of the basics. So my understanding from the patients that we've recruited so far is that everyone who's had COVID had some degree of microclotting.
Okay, thank you so much. And do you have any idea when that information will come out, like be published?
Yeah, there's going to be longitudinal follow-up on this to see whether or not... So I guess what we think might be happening is that COVID is inducing a sort of immune inflammatory vascular reaction to some degree in everybody. And for some reason in the long COVID patients, some ongoing driver that's causing that chronic inflammation to persist. So whether it's that they have some genetic predisposition to getting a more maladaptive immune response, or whether they get more endothelial damage, they're exposed to a higher viral load, or whether they something else, or whether they have more there's viral persistence there and they're not able to clear the virus. We don't know yet. With regards to those that don't get symptoms, there's going to be some longitudinal follow-up to see if the clots over time just break down and go away. We don't know yet either.
Thank you.
Thank you. And I invite you to join our network. We have we'll be posting a contact form. It's probably in our bio as well. We have meetings every day in our network. We have a really awesome community of people, and we can get into more depth with your situation and questions. We'd love to get to know you. So I invite you to join our network. And
thank you. I joined.
Yeah.
Thank you. After the last meeting I participated in. Thanks so much.
Okay, yeah, great. I invite everyone here to join our network. We have a great supportive community. We have in-depth conversations every day. there's opportunities to get involved in the work or just simply get support. There's a place here for everyone. And also, very exciting announcement that we have a long COVID symposium coming up very soon. There'll be announcements for that. So please make sure that you're following us on Twitter so you don't miss any of those announcements. We're going to be having experts from different areas of long COVID. So it'll be a great event, very comprehensive. And of course, like I said, we are releasing today a long COVID resource on our website, worldhealthnetwork.global/long COVID. So please navigate there and back for updates. Thank you so much. And if we could have Yanir maybe wrap things up for us. Yanir, go ahead.
I just wanted to thank Ray and Claire for providing such helpful information and really taking a leadership role in this major challenge that we're facing. I'm sure that the patients that come to you are receiving extraordinary attention and care, and we hope that will spread from there as through their experience and through your communications with others and through our events, so that becomes the standard rather than the current conditions where people are often being paid attention to. So thank you really very much for what you've been doing and for joining us to share that information.
Thank you so much, Yanir. And again, thank you, Claire and Ray, for your time today. I know you guys are so busy with the work that you're doing and the research and the clinical practice. So we really, really appreciate it, like Yanir said. And just a reminder to everyone to please go ahead and follow us here on Twitter. And you can also sign up for our newsletters and join our network. And we look forward to seeing you again for our next event here on Twitter Spaces, as well as our upcoming long COVID symposium. There'll be sign up information posted on our feed soon. So everyone have a great day, a great night, wherever you are in the world, and please stay safe. And thank you for all of you do. Thank you so much.
Thank you. Thanks for listening.